So this is my first case. So this is a 21-year-old boy, and he presented to my OPD with an uncontrolled blood sugar. So he gave a history of type 1 diabetes since 3 years and on insulin. He was on mixed 25-15 units, and he had HbA1c of 11.4. So he came to my OPD in November 2024, and his fasting sugars were high and 200 plus and 300 plus, and urine acetone was normal, and his BP was normal, and he had no other reports. He just stepped into my OPD for control of blood sugars. That's it. And family history, and his mother is a diabetic. She has an past CABG status, and father passed away, and some health ailments that was not available. Details were not there. One sibling was normal, and when taken the proper history, he said his father doesn't seem to have a diabetic, and even from the maternal side, even there was no history of diabetes. And personal history is a non-smoker and non-alcoholic, but the patient was highly stressed because he's an IT professional and he works in night shifts. And other bowel and blood habits was normal, and medical history, there was no surgical history, but he had only one prior admission of DKA. And he was initially diagnosed with diabetes. So he was thin built with BMI was very less, and there was no dehydration, and all the pallor, cyanosis, everything was normal, and there was no acanthosis. He was thin built basically, and systemic examination was normal. And so I believe that it's a case of type 1 diabetes. He just came for follow-up for better management. So I switched the insulin to basal bolus therapy, which we generally do for any type 1 diabetic patients, and advised self-monitoring of blood glucose given a blood sugar chart. So, and he was to be reviewed after a month, but the patient reviewed only after 3 months, and he gained weight. So and when looking into the SMBG history, I could see there was a lot of glycemic fluctuations. It was not at all normal, like it was a sleep, more of a low sugar sort of thing. So, so as a patient, we know like type 1 diabetes, they have the liberty to adjust the dosage, because once we are type 1 diabetes, they are always used to that adjusting sort of things, and so he adjusted himself. And but HbA1c is not done. So, but BP was normal, and again it was fine-tuned. The insulin dosage was fine-tuned, and again the basal bolus therapy was again initiated, and he was asked to review Nebic. I just wanted to know what is this type 1, the insulin reserve status. So I asked him to come with a fasting C-peptide, but to my surprise, it came to be 2.24, which was within normal limits. So this 1 to 4, so it was 2.44. So I was a little surprised, like whether am I dealing with really and type 1 diabetes. So my diagnosis totally revised to either am I dealing with MODY or sort of a malnutrition associated diabetes or type 5 diabetes. Since the patient's insulin reserve was good, so I started off a low dose of glimepiride and metformin, and for morning and night the insulin was continued, so I reduced the insulin dosage. And I just wanted to know the UACR ratio and renal function test and scan abdomen, because I wanted to rule out whether it's in type 5 or in MODY. Basically, I thought like that, because for MODY 5 and all, which was basically a thin built individual, we had some generation, like the 2 generations were not there, but I know the mother is a diabetic. So I thought, am I dealing with, I was so excited, like am I dealing with MODY and settle. So I was thinking of doing a genetic panel and scan abdomen, so to know any other genitourinary abnormalities is there, something like that. But the patient attender, so they were very reluctant, because they have spent us like any other patient. No, whenever we tell them, like we are so concerned of the patient, whenever we tell them like do some investigation. So we just wanted to make sure that we are in the correct track or not. So as like any other this thing, they were not. They were totally reluctant, and they have spent so much for the mother of CABG and other things. They were not so happy to that. But though I told them to do the same. But what happened was that within 10 days, he came with severe pedal edema, and blood sugar and BP was so high. So I was again, and so I just went for a cardiac opinion. So. And again, we have a hospital setup. I asked the patient to go for cardiac opinion in my hospital. He said that he wants to go elsewhere else, and he was not again willing. So the importance of the investigations, I told, like it has to be done and something and all. So, but anyway, he visited a cardiologist, and the patient was started on ARBs. So, and again, within 10 days or so, he presented to my OPD. Suddenly, one day, he came up with a random sugar of 670, and but the ketones were negative. But there were signs of dehydration, and again told them that you have to get admitted. So because I can't do anything with 670, I can't send you out. Like, I want to know what is really happening with you. So so he was admitted. So by on admission, his creat was high. He has overproteinuria, and the scan abdomen showed calculus pancreatitis, chronic calculus pancreatitis with pancreatic duct around 6 mm. And fundus, again, we went on doing all sort of workup, and it showed he has proliferative retinopathy. So, and again, the patient was stabilized with insulin, and the gastronephrocardioc uplesion was taught, and he was taught again discharged. But after discharge, what happened that his blood sugar was erratically going down. Even with 2 units of insulin, he was going for severe hypoglycemia as low as 27, that he became so unconscious even at night time. So they used to call me at night. So so that was a thing. Like, so I thought like there is some sort of like I had though the insulin, the C-peptide level was normal 1.5 2 months back before, so I literally thought that the C-peptide level should be coming down because the insulin reserve is, I think the patient is losing beta cells along with an alpha cell, so that I could see from the SMBG chart that even though they give the glucose, it slowly picked up. The blood sugar slowly picked up. It was not as spiking as we see in any other patients, like blood sugar levels. So I could see. So I thought there is again an alpha and beta cell is lost. So I just want to again redo the labs and again send the patients for fasting C-peptide. I asked him to come back again. So, but within that, the patient again got so the patient had throughout the history from November for the past 4 months, he never had a history of abdominal pain. So that was the thing. I don't know. So when we asked any maybe FCPD was never in my thought before. So I didn't know, because I was thinking only of type 1 previously. Then I thought that it could be an MODY or type 5 something, malnutrition. So but again suddenly he came again with severe abdominal pain, but though and serum amylase levels were slightly elevated, not much like, but it was slightly elevated, and the blood sugar was very high. Again, patient was put on insulin, again infusions, everything went on, and fasting C-peptide came to be again 0.5. So, and the final diagnosis of FCPD with all the microvascular complications of nephropathy and retinopathy was made, and at last the patient lost follow-up. So that was the case. So I just wanted to present this case because FCPD, I think whenever you have a patient of an young age, it's not always type 1. First point. Then I think we should not go by the history of what the patient says. I think like when the patient told me that he was diagnosed as type 1, somebody outside has told him he's a diabetic, he's type 1 and he needs insulin for lifelong. So literally I believe the patient. I think I lost workup, like I was lost in patient's words, and maybe I should have done something regarding that. I think in our busy schedules, whenever we have an young patients of 25, we have an armamentarium of diagnosis. Not, it could be type 2, it could be type 1, it could be in MODY, it could be in FCPD, it could be in secondary diabetes, any sort of secondary diabetes, hemochromatosis, so type 5, so anything could be there. So I think when you have an young patients, we should be little careful, and we have to spend little more time digging into the diagnosis so that you put the patient proper treatment. So I don't know, like when I checked the blood pressure, it was normal whenever the patient came to my OPD, but like maybe that I would have missed. I think like yeah, what I felt was suddenly it will not jump from normal to an accelerated hypertension within a month, I think. So I think that was a mistake by the nurse or something else. Maybe I should have taken the blood pressure, but I didn't had I never thought that it could be otherwise. So I think that's all I wanted to make a point here. So coming back to FCPD, the ages between 15 and 45 years were diagnosed, it should be a thin built, and there will be a pathology of CCP will be there, and autoantibodies will be negative, and C-peptide could be low, so it will be progressive decline. So when I saw the C-peptide, it was initially normal. So, but after that, it just drastically dropped down. So that I think that is the very peculiarity of FCPD, and the blood sugar will be erratic, very erratic. So they will be ending up with an early microvascular complications and early renal involvement, and they will be needing enzyme supplements for the exocrine pancreatic deficiency. So Coming to the type 5 diabetes, which is in malnutrition related diabetes, I think they will have an. I think the point that could be difference would be I think the pancreatitis will not be there in type 5 diabetes, and again the age of onset will be similar, 15 to 30 years. And there will be a long-standing protein calorie malnutrition, I think, and there will be a weight loss and no abdominal pain. And yeah, that is the very peculiarity. And but there will not be any family history that differentiate from the MODY5. And the exocrine involvement will get, and it will have a normal pancreas. So when you what differentiates it from MODY5 is that it is again a 2 generation, and the ketones will be normal, and the pancreas could be on the lower. Pancreatic reserve would be on the little lower side, like when it is around it will be around 1. So that is where that is differentiate, and you will be having some genitourinary abnormalities. I think these 3, I think you have to be little when you dig in the history, you could easily identify. So all young diabetes is not type 1. Always think of the alternate diagnosis, and C-peptide measurement is very crucial. And whenever they have an abdominal pain and rapidly fluctuating sugars and very erratic, and when there is an exocrine involvement you feel of, always do a scan and rule out the pancreatic pathology. This is another case. I lost this patient, but this is again an eye opener. Like in my previous years, I still remember the patient, and this is a 73-year-old female, Lakshmi. She's a known diabetes incident. She's a very meticulous patient. She'll be coming into an OPD every 3 months. She will review with her daughter. HbA1c always under control, less than 7. She was an act rapid insulin. She was taking around 40 units per day. She was thin built. She was basically with Telmet, almost should be requiring. She was taking around 1 units per kg per day, and on one particular visit, HbA1c was 8.4 with blood sugar was elevated. So I was asking for any other complaints of any infection is there. So basically we think of that, whether they have skipped insulin, whether they have not, the shelf life of insulin was lost, something and all of this. I was just taking the, what I think, like, I was just digging the history, but she didn't have any complaints. So the attenders reasoned out it could be due to recent feasting because of the granddaughter's first some marriage, something and all. So I just thought, so it was just one time it has went ahead. So we'll just think of the next side. So I asked them to review after a month, but the attender said they are from a very far place, asked like any other attender. So they insisted for a 3-month review. For the next review, it was again HbA1c was 9.6 and the blood sugar was very high. And suspecting a mitotic lesion of this age factor of 75 and 73 plus, I suggested a mass checkup. And I suggested them, like, because we are not sure where it happened, so I just want to make sure that we are not missing out something, like. And there was a mild weight loss. So, and suddenly she complained of some chest. So when she was about to leave, she said that I have some pain in the left chest. So when she just opened, then I found an immobile hard mass. She was very thin. So whenever I asked her to even, I couldn't feel that mass. So generally we don't palpate the breast for any patients unless it is warranted, right? So this patient had immobile hard mass. So that was found to be in stage 3 severe breast. And this patient, she didn't go for any investigation. I'm sorry, she didn't go for any treatment. They were not really pain treatment, but still she was able to pull on for another 2 to 3 years, and later on she passed away. So the learning point from this particular patient is that in elderly patients with long-standing diabetes who suddenly has a poorly controlled glycemic control despite a very good compliance, we should look beyond the lifestyle dietary cause and consider the underlying secondary causes, including malignancy and infection, something and all. So, and a careful clinical examination can uncover the diagnosis early. So I think that finishes my talk, and thank you for the patient listening.